Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. We have previously talked about consent a lot in our podcasts, and if you're interested, there is an MPS podcast series about consent on episodes 2 to 7. Today we're talking about day of surgery consent, and that's for elective surgery. My name is Chow Yen Chen, and I am lucky to be joined by Dr. Tim Cookson, retired GP and medico-legal advisor, and Adam Holloway, partner at our panel law firm, Watankani.
Hi, Jan.
Hello.
Thanks for having me on, Chow Yen.
Thank you for joining me. Recently, the Health and Disability Commissioner has made critical findings on consent that was done on the same day as elective surgery. We know that in our resource-constrained environment, waiting lists are long, many surgical lists are pooled, and so it is common practice for the patient to be seen by a surgeon in clinic, placed on the waiting list, and then present for surgeries months to years later for an operation by another surgeon. This is challenging for doctors and patients as there is risk of new information on the day of surgery, change of technique, and maybe even issues arising from the normal process of booking some operations, like hook wire biopsies, where the placement of the wire will determine the surgical technique on the day of surgery. We've had a number of cases where the HDC has upheld these complaints. So to start, Tim, would you be able to tell us about some HDC cases about about consent obtained on the day of elective surgery that's gone wrong?
Thanks, Jane. There's certainly been a number of cases, and the Commissioner seems particularly interested in these cases. And the patients involved are obviously really perturbed by what has happened, and really have had the feeling that they've been forced to make a decision for which they didn't have the full information. And that's the crux of it. So one example is a fairly recent one, a hernia repair case. Now, the patient had some concerns about mesh, but it hadn't been decided previously whether mesh would be required for the surgery. But she knew that sometimes it was, and repeatedly tried to speak to the surgeon before the procedure, but was unable to do so. And so it was on the day of the surgery that it was put to her that actually mesh might be a good idea. She was only given a few minutes to decide and really felt compelled to agree because she was concerned that if she didn't agree, there'd be delays and whatever. So, and she really did want to get the surgery done. She'd been waiting for quite a long time to get to that point. And the Commissioner found that this consenting was inadequate. The woman clearly had concerns about mesh and just being given, a few minutes or half an hour to make a decision about whether or not she would have mesh with her surgery. It was a significant factor for her. And the Commissioner emphasised the need for an environment that allows sufficient time to consider the information and alternatives that there might be. And the Commissioner was also concerned that there were system issues that blocked any contact between the patient and the surgeon concerned, because obviously if she'd had a chance to talk to the surgeon, that might have all been sorted well in advance, and the consent would have been without coercion or a feeling of coercion. So, that's one example, but as you say, there have been a number in recent times.
Yeah, and I think for that one in particular, the hospital, for its lack of process, was breached because, like you say, the patient did try on several different occasions. I think the HDC noted 5 different occasions where the patient tried to phone the hospital to talk to the surgeon, but her message wasn't communicated. And ultimately it was that process that was breached by the Commissioner. And I think that comes up a lot, that patients, because our health system's complicated, booking surgery is complicated, and there's so many different people involved, that patients feel like they can't convey their concerns.
And of course, mesh has a particular connotations to it because of all the disasters that occurred with gynecological mesh use, and yet for use in hernias, it's actually really good.
Yes.
But that's not information that's clearly understood out there in the public. And, if you mention the word mesh to the average patient, particularly a woman patient, they're going to say, no, that terrible stuff. So it was understandable that this woman did have real concerns about the mesh and needed a clear explanation as to the difference between gynecological and hernia repair use of mesh, and the benefits and lack of complications relatively in that latter use.
That's right. And that was information that was particularly pertinent for her.
And I think there was also an issue too that it hadn't been decided really until an ultrasound confirmed that in fact a mesh was likely to be the best option, and that information wasn't available during the early stages when the initial planning was made.
Yeah, it's really difficult for patients, I think, when they're faced with these decisions. And a key issue that's come across is that consent must be freely given, but in these situations when they feel significant time pressure and the risk of not receiving surgery that they've waited months and months for, I don't think that consent can be considered to be freely given with those issues. Adam, what do you think about this particular case?
Yeah, it's on all fours with a number of cases in the sense that the commissioner, the HDC, will always look sceptically at an instance of consent where there's been regret from the patient and the change in technique or what it was that was going to happen to the day that consent was given in a pressured situation or with no ability to go away and reflect and have time. The key elements of consent in the HDC and the Code of Patient Rights are competence, so that you have to be confident that your patient's competent to give consent. There has to be effective communication between the parties, and that can raise issues such as level of understanding or language, different cultures, etc. There needs to be provision of all the necessary information to the consumer. And if that's happening in a rushed setting, there can be questions around that. And finally, the consumers has to give their consent freely. And allowing a consumer to both be adequately informed and then give consent freely. Sometimes the secret sauce is actually just time. Another way of saying that is that consent is a journey, not an event. And if the journey's not long enough, then it can be hard to convince the HDC that the consent was sufficient. So to be free of that coercion, that sense of pressure that lots of people would experience in a hospital where there's this huge machinery of people and activities taking place around you, and the sense that you'll be letting all of these people down if you suddenly say, look, I'm just not comfortable. I think that can create a lot of pressure on lay people. And sometimes people will require time to go and speak with loved ones, to read a pamphlet or a booklet on, for example, the use of mesh, and actually think, okay, well, do I have questions about this? So there's lots of reasons why trying to update consent or finalise consent at the last minute is quite perilous for clinicians. And if you're thinking about the balance of, on the one hand, do I go ahead with this consent that's been given that ultimately may be criticised, versus do I take the risk of a really unhappy patient who's now going to have to wait a bit longer for surgery, or have serious complaints about the hospital's resourcing? You might want to choose the latter. That it's a complaint directed to the system's inability to provide prompt surgery is going to be better for you as an individual than you, as the holder of that clinical responsibility, decided to proceed, even though there was a material change that was presented to the patient at the last minute. So it is. It's there's some very important things to try and get right to satisfy those four elements. What the medical council has to say about consent, and this is how they describe it: informed consent is an interactive process between a doctor and a patient, where the patient gains an understanding of their condition, receives an explanation of the options available, including an assessment of the expected risks, side effects, benefits, and costs of each option, and is able to make an informed choice and give their informed consent. So that doesn't speak specifically to time, but there's so many HDC decisions and precedent that we know that proceeding with day of surgery consent, where there's a change from what was being agreed in clinic, is going to be risky. And for the HDC, I think consent cases are always high on their list of things to put resource into. Fundamentally, that the organisation had its genesis in a consent problem.
Yes.
The Cartwright report was about lack of consent, and the spiritual heart of the HDC is that issue, more so than anything else. So it's not surprising to me that cases about consent, and particularly gynecological cases, mesh, because it's such a social political issue, are going to attract an awful lot of scrutiny.
Absolutely. Excuse me. So there's been other considerations and complaints to the HDC. And Tim, are you able to talk about the one where a patient wasn't aware that team members such as registrars were going to be involved in surgery on the day of surgery?
Yes, so this was a lady who was having plastic surgery, and on the consent form it actually listed a specific surgeon as being the operator. Now, I can't remember whether there was confusion about that and whether it was just that surgeon was the consultant under whom she was admitted, or whether it was specific that they would be doing the surgery. But certainly the woman formed the view that this particular surgeon would be the operator. And with plastic surgery, it actually the person who does the surgery can be quite important to the individual. And yet, at the time of surgery, she discovered for the first time that, in fact, it wasn't the consultant surgeon who's going to be doing the operation, but it was a registrar and a fellow who would be performing it under the supervision of the consultant, but still the hands-on was going to be virtually all from these other members of the team. She'd not been advised that this might happen, and there'd been no, for example, documentation that the roles of a fellow versus a registrar versus a consultant had been explained to us, so it was all kind of new material. Interestingly, the commissioner found that she was entitled to know not only who the responsible clinician was, well, that's clearly the person she was admitted under, but who would actually do the operation and in what role. And of course, that raises all kinds of problems within a public hospital system because, it's often very unlikely that the person who does the initial clinic assessment and does the initial consent process is going to be the person who's doing the procedure. And so if that's going to be the situation, it needs to be clearly stated to the patient right at the outset, look, you'll be under this team, but there is no guarantee that it'll be any specific individual who will be doing the operation. And this is a hospital with registrars, so registrars will be involved to the level of their competence, supervised by a consultant. And that all has to be clearly understood by a patient before they can give the freely given consent that Adam was talking about. And so the Commissioner did conclude that the consent process was inadequate in this situation, and that the provider as a whole had breached the code by failing to ensure that she had been properly informed in advance, and also in a setting that wasn't pressurized for her to make a rapid decision. I have to go ahead. And yeah, as Adam was saying, there's a huge degree of pressure on a patient who's already lying on the bed, ready to be transferred to the operating table. Everyone's gathered around, and they're thinking, "Oh, crikey! If I say no, all these people are ready to go. They're going to have to organise the next patient. Okay, I'll do it." But that's really not a freely given consent scenario, so it's not surprising that the Commissioner did come to that view. And so, it's just that prior information. We just got to think, much more carefully about what a reasonable patient would expect to know, because that's what the Commission is concerned about. What would a reasonable consumer want to know in those circumstances, instead of thinking, well, we've got a system that needs to do this and this and this,
right.
and become a little more patient focused as opposed to proceduralist focused.
Yeah, so separating the scheduling issues from the actual consent. And like what you're saying about prior information, I know that on the day of surgery there's a lot to do, but you also have that opportunity in clinic way back when you first see the patient to explain that system, to say, I'm seeing you today, but it may not be me operating on the day, and you might meet a different surgeon with a team which will consist of X, Y, Z. And that's common in anaesthetic practice as well, because we see patients in clinic, but we may not be anaesthetising them. So it's definitely worthwhile, having seen all these issues, to understand that part of consent is to share with the patient what the process will be. Because I think that's so overwhelming. They get so many letters, so many phone calls. But if someone had told them some stage in clinic or before they came to theatre that this would be what they could expect on the day, I think that would help a lot.
And there are situations which actually become quite complicated. I can think of, hip replacement surgery where there may be a couple of recognised techniques that are quite different, but the results are pretty much equivalent.
Yes.
And a surgeon will train up in one of those particular techniques. And the surgeon who does the consent and explains the procedure might be one who does method A, but the one who's doing the surgery does method B. And so it really falls on the surgeon who's doing the consenting process to say, to cover that option and say, actually, although I do this particular one, there's also another version that equally good results. The surgeon who operates on you may do either one of those two. This is what you could expect in either process.
Yeah, that's so true. And I think in the situation that we all find ourselves in, where we have pooled patients and you really don't know who's going to be operating on you, I think that's the safest way forward, is to explain that it may not be me. I do it this way, but someone else may do it this way. And please consider that not both ways are perfectly appropriate for your condition. And so there are other situations. We talked about mesh briefly, and there was another case where a woman in her 50s had planned hysterectomy surgery. And in that case, on the day of surgery, quite a different procedure was proposed to her. Adam, would you be able to talk to us about that one?
Yeah, this is another HTC case where there was a breach finding. And at a high level, the facts were that the plan that was explained to this patient and that was consented was for a hysterectomy with a bikini-lined incision, but on the day of surgery, the plan changed. And I can't remember from the decision precisely why there was the change, but there could have been, an MDT input and various reasons why the surgeon then responsible, being different from the consenting surgeon, thought, well, actually, to provide the best care to you, there's both a different approach and a different thing we should be doing here. And what was presented as the procedure on the day was a recommendation to remove both ovaries and use a midline incision. The patient in her complaint to the HDC reported only having about half an hour to consider that significant change, and particularly removing ovaries is not a small thing. And again, and this is a theme in these cases, reported feeling pressured to proceed because she had already been prepped and was waiting for surgery. And so there were criticisms about the consent form and the documentation, what was captured on the day in terms of discussing all of these, the implications of removing ovaries and alternatives, etc. But I think in a sense, the documentation is for me anyway, a smaller piece of the puzzle. You do need to have a written consent for surgery, and your written consent can provide good evidence about the consent process, but the consent process is more than a document. You shouldn't feel insulated from criticism as a doctor because you've got a signature on a piece of paper. A patient can still say, yeah, I signed that, but it was 15 minutes before the procedure and I felt like I had to, and the HDC will still be interested in that. In that case, there was a really detailed analysis of the journey the patient had from, back to seeing registrars in clinic all the way through to surgery, and you can expect that sort of level of examination. The Commissioner found ultimately that the environment on the day didn't allow for open and effective communication, and that the patient wasn't given sufficient time. It was accepted that some system issues contributed to that. The pre-admission documentation was poor. The surgeon didn't get to see the patient pre-admission themselves, despite the booking form requesting that, and that the hospital processes had failed to ensure the surgical plan was clarified at an earlier stage of the process. So I think what we can learn from that, and it's very consistent with the discussion Tim and Xiaoyi and you were having before, material changes to a surgical plan really shouldn't be raised on the day of surgery. If you're a new surgeon coming to this and you want to do it a different way, I think you have to seriously consider whether it's the right idea to proceed, or you actually say, look, I'm really sorry, but I don't feel comfortable offering you the procedure in the way that it was consented.
Right.
I want to do this other thing. There are really good reasons for it, and I'm going to explain them all to you, but you're going to need time to think about it. And we're going to have to make a plan around that.
And that was the frustration, I think, for the surgeon, because they read the notes prior to well in advance, knowing that they were going to be doing the procedure, realised that what they would want to do was different from what the original surgeon had suggested, tried to organise the booking so that they could be seen, have a chat with them, get the new consent for the new procedure. And so the surgeon, I think, felt almost as coerced as the patient did at the time. Yeah. Oh God, the system's letting me down. This woman really needs her operation. I think she understands what's going on. Yeah, let's go ahead. And in the light of day, think about afterwards, no, look, I was operating under pressure. I was feeling, a lot of influence to get this done rather than to wait, even if it was this kind of a self-imposed pressure.
And it's interesting, I don't read this HTC opinion as saying, as hardline as you can never get same-day consent for an elective procedure. And I don't know how practical this is in terms of the way hospital systems operate. But if it were an option to realise there was going to be this issue, be able to step out, have a really good and well-documented conversation about it, and say, do you know what, we're delaying you till the end of the day. I'm going to put you at the end of my list. I want you to go away and talk to your family. I'm making another time this afternoon where I will be free to meet with you again in case you have questions. And if you wish to proceed at that stage, I'll do you last. And if you don't, that's fine.
I'll offer you a different surgical date.
That's right.
Yeah.
That's right. And I think, you can imagine, and it may be really challenging to organise something like that, and perhaps impossible in some circumstances, but you can imagine a way of doing it where you could get consent on the day that is beyond reproach. But saying, look, you booked for 9:30, we're going to do this at 9:30, if you give me consent, or you've marked us all around.
That's not free consent.
Is not the way to go.
Yeah, so on the day, that's absolutely right. What you don't want to have is the patient who feels incredibly guilty because they've mucked up, in inverted commas, the system. And also, if there's going to be a delay, you need to be able to reassure them, well, you're not going to the back of the waiting list.
Yes.
You'll be at the front of the waiting list. So we'll organise something for next week or whenever you've had sufficient time to actually, make sure you understand fully and are happy to give consent without a feeling of coercion.
Yeah, absolutely. And I think that those principles definitely apply to all aspects of consent on the day of elective surgery, including if there's a specialist visitor or a surgeon like you're talking about who can offer a different or an improved technique. Because, the commissioner's not out there saying you can't have the procedure that's most appropriate or that will give you the best outcome. They're just saying that you need to be able to communicate the information in a way so that the patient doesn't feel coerced into making that decision. Oftentimes they've met the surgeon for the first time on the day of surgery, so they haven't been able to establish a rapport or understand what they're trying to explain. So I think what you're saying about time and offering a different day, if possible, or changing the scheduled time of surgery is really important. And also discussing with the patient that there's different ways of doing things so that they're not fixed on a particular technique is really important too.
And another kind of aspect to think about would be, if you're in that situation, you felt like you've had a good conversation on the day, you feel like your patient has had sufficient information and time, is to then think about, well, hang on, if something goes wrong and this person has a significantly adverse outcome, can I rely on this consent as being freely given or not? And I think if you have a doubt then that you'll know in that situation, it may well be that the patient will change their mind and say, no, actually, I did feel pressured to have this and, here's my outcome.
Yeah.
And, if you think about that possibility, maybe that might influence your decision about how important it is to go ahead on the day as opposed to organising it at a later time when that factor is no longer there.
Yeah, and I'd be interested in your views about surgery where, for example, that requires a hook wire placement or a particular diagnostic procedure that determines the surgical technique that's done on the day of surgery. So, for example, in some breast biopsies, the patient goes and has a hook wire placed on the morning of surgery, excuse me, and then that placement can determine how the surgeon then does the biopsy. So you can imagine in those cases, it can be difficult to defer them to the next day. And we've certainly had cases where complaints have arisen because the wire placed has meant that the surgeon has to take a different approach.
I mean, I guess part of what you'd hope people listening to the podcast take away is to be able to recognise a high stakes consent situation has arisen. That if you are, going through something you've probably done 100 times in clinic, where you've got all the pamphlets and people can go away and think about it, and that's a different situation from needing to decide whether to proceed on the day, and recognising that for what it is, so that you can become the best version of yourself. Yes. in terms of doing consent, and bringing all those skills to the fore of knowing when to slow things down, not just asking a patient, like, I've given you a lot of information, did you understand everything I've said?
Yes.
Is that not sufficient?
It is a lot less potentially helpful than being able to say, okay, I've explained a lot to you right now. It'd be really helpful for me if you can now just, I would like to hear from you what you understand about the situation that we're facing. And actually get the patient to ideally verbalise, I know that one of my options is not to go ahead today.
Yeah.
And even psychologically, that buy-in is going to be really helpful. That the patient has understood enough to be able to say back to you, I understand that this wire has been placed in a different position from what you were expecting as a surgeon. We're either going to need to get that moved, that may not be possible today, or you're going to have to use a different approach. This is what that means. This is what I've understood you to be telling me. But I also know that one of my options is that I can just not go ahead.
And I guess with the hook wire situation, another alternative would be to say, look, these are the various possibilities. I can't predict in advance because it's going to depend on the placement of the hook wire, which of these things is going to happen. Are you happy that, any one of these three slightly different processes might occur? Do you understand what I'm saying? And tell me what your understanding is of what we're about to do, and your understanding that the exact process won't be known until we actually get into theatre.
That's right. And also, excuse me, seek a second opinion, talk to a colleague, and of course, document. Document like it's a journey, not a signature on a page.
And it's probably worthwhile just adding in, even though it's slightly different, but it's allied, for the surgeon who goes in, for example, doing an abdominal operation, discovers something that had been unsuspected.
Yes.
And thinks, oh, I can help this patient by removing this particular little lesion at the same time, for which there hasn't been no consent given. And the commissioner has in the past been very clear that is not appropriate. And that even though it seems crazy from a medical point of view, you just need to close up the patient and then have the discussion with them the following day or whenever they're competent to understand that actually there's something more we've discovered, we need to do something about it, but I couldn't do it at the time of the surgery because you didn't know and we had no consent for me to proceed.
Absolutely. All right, and I think I'd just like to add that it's always helpful if the hospital that you work in or the organisation you work in make available to the patient some way of contacting them to say, I really need to rediscuss my surgical options, or I'd really like to come back to clinic, or I don't want to have surgery anymore. Just some way for the patient to talk to the hospital and the surgeon about their surgery because many of these cases, the primary issue has been not being able to communicate about their surgery, and the hospital having so many different processes that it's difficult or impossible to navigate for the patient.
So it's a combination of communication and time. Is that the
Absolutely
the essential ingredients?
All right. So, any final comments about same-day consent in elective surgery?
Yeah, well, I think I'd just like to reiterate that if a clinician's ever in that situation, they need to be well aware that this is not a normal consenting process, and that if it comes in front of the commissioner, it's going to be examined very carefully, and that the patient who just mentions the word "I felt coerced" is going to be a significant negative factor in the process. So, think very careful about the potential alternatives that you have before proceeding with a consent on the day where there's a significant change in the planned procedure.
Yeah, and you not only do your best job of re-consenting for the change, and being prepared to pause, give enough information, give time to decide. But as I think you've mentioned, Chow-Yen in particular, it is important, I think, to communicate that you're not going to be penalised for saying no, that you'll work with that patient to make sure that there won't be a penalty in terms of access or cost if they decide that they do need more time. Last thing I'll say is probably also, you don't know what you don't know, and there may, for example, be something arising from a change of technique that has a cultural component or something that's particularly important to that patient that is just a blind spot for you. So that's another reason why these are high stakes, and that you really need to have slowed yourself and the situation down enough to be able to explore what the changes might mean for this individual in terms of where they're coming from and their personal and cultural circumstances.
Absolutely. So thank you both for joining me today. Thank you for listening to this podcast. I hope it's been helpful. Our podcasts provide information of a general nature. If you would like advice on a specific case and you are our member, please contact us on 0800 2255 677 option 3 during business hours. We look forward to catching up with you in our next podcast. If you like the Medical Protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org.